Welcome to the HEOR Insights YouTube channel.
In this explainer, we're going to break down the ROBINS I tool. It's become the absolute standard for assessing bias in non-randomized studies, which is something we deal with all the time.
So here's our game plan. First, we'll cover what ROBINS S actually is. Then we'll dig into the target trial concept, which is key. After that, we'll walk through the 7 domains of bias, look at how scoring works, and see how it's used in HEOR practice. And we'll wrap up with some key takeaways for you.
To really understand why ROBINS I is so important, we first need to talk about the problem it was created to solve. And that's the credibility gap that often exists with real-world evidence.
You see, in health economics and outcomes research, we constantly face this dilemma. On one hand, you have randomized controlled trials, or RCTs. They're the gold standard for proving something works because they have high internal validity. The problem? They often don't reflect what happens in the real world with actual patients. On the other hand, we have real-world evidence, or RWE, which is essential for our work because it has great external validity. But it's much more likely to be biased, especially from things like confounding. And this makes HTA bodies, like NICE in the UK or CAPT in Canada, pretty skeptical.
So this is where ROBINS I comes in. The name stands for Risk of Bias in Non-Randomized Studies of Interventions. It was specifically developed to tackle this challenge, and it's now the go-to tool, accepted internationally, for systematically checking the credibility of RWE. Now, you can't just jump in and start using the tool. To apply it correctly, you really have to grasp its core philosophy, and that's all built around something called the target trial concept.
So here's the key idea. ROBINS I doesn't just grade an observational study on its own terms. Instead, it asks a very specific question. How different is this study from a perfect, hypothetical RCT that was designed to answer the exact same question? The entire assessment is about measuring how far the study deviates from that ideal.
And this leads to a pretty rigorous starting point. Think of it as a guilty until proven innocent approach. See, with tools for RCTs, you kind of assume the study is valid unless proven otherwise. But ROBINS I flips that. It starts by assuming bias does exist because there was no randomization. The study's evidence then has to prove that the bias was minimized enough to be trustworthy. Okay, so how does the tool actually do this assessment? Well, it's all structured around 7 very specific domains of potential bias.
And to make things logical, these 7 domains are organized by time, basically following the life of a study. They look at biases that can sneak in before the intervention even starts, at the moment of the intervention, and then everything that happens after, during the follow-up and analysis phases.
All right, so here they are. The big one for us in HEOR is number 1, bias due to confounding. This is so critical because of confounding by indication, where the reasons a patient gets a certain treatment are also related to their outcome. Then you have bias in selecting participants and how interventions are classified, bias from people not sticking to their intended interventions, bias from missing data, bias in measuring outcomes, and finally, bias in how the final result is selected and reported.
So after you've worked through all 7 of those domains, the findings get combined into an overall risk of bias score. Let's take a look at what those scores actually mean in practice.
There are 4 main categories. A low-risk rating means the study is basically as good as a well-done RCT. Honestly, this is incredibly rare for RWE. Moderate risk? Now that's the gold standard for real-world evidence. It's what you're aiming for, and it's generally considered acceptable for HTA submissions. A serious risk rating flags some major problems, and you'd really only use that study in a sensitivity analysis. And finally, critical risk means the evidence is just too flawed to be useful. You'd exclude it from your analysis altogether. And it's really important to set realistic expectations here. When you conduct a systematic review of real-world evidence using this tool, you often end up with what people call a sea of red. That just means that most of the studies are rated as having a serious or critical risk of bias. So achieving that low-risk rating, it's highly, highly unusual for an observational study.
Now, this whole framework isn't just an academic exercise. It has very direct practical applications. ROBINS I really acts as a critical gatekeeper for evidence in some key HEOR activities.
Let's walk through a common high-stakes example, external control arms, or ECAs. So a pharma company might submit a single-arm trial, and they'll use real-world data to create an ECA for comparison. The HTA agency will then take that ECA and put it through a ROBINS I assessment. Now, if that tool spits out a serious or critical risk rating, well, the agency is very likely to reject the comparison. And that can have a huge negative impact on whether the product gets reimbursed. So the primary places you'll see Robin's eye used in HEOR are for assessing those external control arms, where it's a make or break filter. It's also used in network meta-analyses to decide how much weight to give to more biased observational studies. And it's also really helpful for validating long-term safety data that comes from real-world evidence.
So let's wrap this up by focusing on the key takeaways for you, especially if you're working in or just entering the field of HEOR.
First off, it is absolutely crucial that you don't confuse Robin's eye with ROB 2.0, which is the tool used for RCTs. Remember, Robin's eye starts guilty. It's mostly worried about confounding, and getting a moderate risk is actually a big win. ROB 2.0, on the other hand, starts innocent. Its main concern is a failure in the randomization process, and a low risk rating is what you expect to see.
So, for your professional role, here's what you need to remember. First, for RWE to be credible, it needs a really sophisticated design and proper statistical adjustments. Second, you have to understand target trial emulation to use this tool right. Third, when you're in front of an HTA agency, you need to be ready to defend your RWE, because it will probably face scrutiny and a potential serious risk rating. And finally, you should use Robin's eye proactively to be transparent about your study's limitations and discuss them openly.
And all of this brings us to a final, forward-looking question for our entire field. How can we get better at designing our real-world studies right from the beginning so we can anticipate and actually reduce the very biases that we know a tool like Robin's eye is designed to find?